AMS programs in healthcare facilities should not be vertical programs. Rather, they should cut across other existing programs to optimize antibiotic use, thereby improving quality of care and infection management. An AMS program should be adapted to the facility's human, financial, structural resources. There are several ways in which healthcare facilities can be differentiated. For instance, they may be private, not-for-profit or public healthcare facilities, district, regional, tertiary or quaternary or central healthcare facilities, with or without a fixed financial budget, with or without their own pharmacy, with or without an on-site microbiology laboratory. It is important that healthcare facility management and an AMS committee and/or AMS team together decide which strategies best fit their local setting, based on a situational analysis and development of an action plan. Let's look at the key steps to establish a healthcare facility AMS program. The first step is to undertake a facility AMS situational or SWOT analysis using the checklist of healthcare facility core elements. Pay attention to the essential facility AMS core elements: human resources, antimicrobial use and resistance data, and AMS activities. The situational analysis should include strengths, weaknesses, opportunities and threats, SWOT, at different levels in the facility, possible barriers and enablers for the full participation of the different healthcare professionals and departments in the AMS program. It will lay out the strengths, weaknesses, opportunities and threats involved in determining how ready the facility is to implement AMS, and paves the way for developing a facility AMS action plan. Before you undertake a SWOT analysis for AMS, the information you need to undertake are the following: map which AMS essential core elements are in place in the facility. Undertake a baseline antibiotic use analysis. Review the antibiogram and AMR data. Identify main challenges related to antibiotic prescribing and use. Identify available human and financial resources for AMS. Identify existing AMS activities. This is an example of a SWOT analysis for planning an AMS program in a healthcare facility. In this quadrant, specify the strengths in the form of internal or present factors that are helpful to implementing AMS. Then identify the weaknesses in the form of internal or present factors that are harmful to implementing AMS. Next, identify the opportunities in the form of external or future factors that are helpful to implementing AMS. Finally, determine the threats in the form of external or future factors that are harmful to implementing AMS. Based on the situational or SWOT analysis, develop a healthcare facility AMS action plan to ensure accountability, prioritize activities and measure progress. This should include the following key components: AMS core elements to be implemented in the short and medium term, leadership commitment and AMS governance structure that may be new or incorporated into an existing structure, AMS activities to be implemented, monitored and evaluated. Ensure facility-wide engagement in the AMS program. Education and training to strengthen key competencies for effective AMS implementation. A budget for the AMS program including human and financial resources. Next, we'll take a closer look at AMS governance structures and human resources. It is essential to have a governance structure that includes the different functions needed to effectively implement a healthcare facility AMS program. Governance structure may vary in size and complexity, depending on the facility. Most important is to identify the responsibility and accountability of the hospital management and of those who are to coordinate and implement the AMS programme. Here's an example of an AMS governance structure for healthcare facilities in LMICs. It is important that the healthcare facility leadership endorses the AMS governance structure and empowers the AMS committee and the AMS team, and that there is a reporting and accountability mechanism between the different levels. The AMS team should consist of a multidisciplinary team. Next, let's look at each of the components in this structure. The AMS committee in the healthcare facility provides leadership and overall coordination of the AMS programme. The AMS team, which ideally should be a multidisciplinary AMS team or otherwise an individual, depending on the availability and size of the facility, implements the AMS programmes. The AMS committee can be a standalone committee or be integrated into an existing structure, such as the Infection Control, Patient Safety or Drug and Therapeutics Committee, with clear terms of reference. The chair of the AMS committee should be responsible for providing leadership support and is accountable for the overall implementation of the AMS programme. The AMS team will comprise multidisciplinary healthcare professionals who implement the day-to-day AMS activities. The composition of the team can be flexible and should be based on existing recommendations and adapted to the local context. You can consider the following options. Option 1. More than 2 healthcare professionals constituting multidisciplinary team. Option 2. A prescriber and a nurse or pharmacists. Option 3. An AMS champion leading the AMS programme with access to expert advice. A clinical leader for the AMS team should be identified who has sufficient training in AMS or infection management to manage the most common issues. Please note that if AMS clinical lead is not a doctor, one should be identified on-site or off-site to provide medical advice and support to the AMS team, which can be led by a pharmacist or nurse when required, and vice versa. And in smaller healthcare facility, the AMS clinical leader may sometimes be the only member of the AMS programme. There are recommended skill sets that the AMS professionals within the multidisciplinary team should possess. These include expertise in infection management, which can be provided by an infectious disease specialist or a physician to support prescribers in diagnosing and managing patients, including optimal use of antibiotics to treat infections. Guideline development, pre-authorization and post-prescription AMS interventions, educational programs on AMS. The next is expertise in antimicrobials that can be provided by a pharmacist or pharmacologist who will help with guidelines and formularies development, overseeing the purchasing and supply of antimicrobials, dispensing of antimicrobials in wards or units, and review of prescription orders, identifying and finding solutions to stockouts and shortages, performing surveillance of AMC and use and analysis. In wards, they review antibiotics prescribed through prospective or retrospective audit with feedback and promote best practices in prescribing, dispensing, and administering antimicrobials. Expertise in patient care is provided by nurses who support the AMS team with providing optimal patient care, promoting timely antibiotic administration and therapeutic drug monitoring, quality microbiological sampling and communication of laboratory results to prescribers, monitoring of patients' clinical progress, side effects or ineffectiveness of medicines, identifying opportunities for IV to oral switch of antibiotics, monitoring the correct handling of patients' invasive devices, etc. Expertise in microbiology is provided by a microbiologist or laboratory technician to process samples for diagnosis and antibiotic susceptibility testing. Feedback the results to the prescribers. Develop and regularly update the healthcare facility's aggregate antibiogram. All these skill sets are recommended for a well-functioning AMS team and program. Remember the Barbados case study? It is a good illustration of how AMS programs are often initiated in facilities or even countries due to an outbreak of multidrug-resistant MDR bacteria. IPC and AMS are two sides of the same coin when it comes to development and spread of AMR, optimizing antibiotic use and providing quality healthcare. IPC prevents healthcare-associated infections, saves money, reduces AMR and supports high-quality, people-centered services. IPC and AMS are interdependent programs that require coordinated efforts and interventions. For AMS programs, collecting data on the use of antibiotics helps to assess the extent and quality of antibiotic use, identify problematic prescribing practices, compare appropriate use across facilities and within a facility, department or ward over time, identify areas for improvement in targeting and monitoring AMS interventions. There are three main types of antibiotic data, which are used to provide baseline information and evaluate AMS interventions and programs. They are 1. Quantity of antibiotics used through collecting antimicrobial consumption AMC data. 2. Quality of antibiotics used through collecting antibiotic use AMU data. 3. Quality of antibiotics used through collecting antibiotic audit data. Here is an image of the pharmaceutical value chain indicating potential data sources for surveillance of antimicrobial consumption and use. For example, antibiotic consumption data can be collected from procurement or dispensing sources. Each type of data has advantages and disadvantages. AMC data refers to estimates that are derived from aggregated data sources, mainly procurement and dispensing data, and serves as a proxy for actual antibiotic use. Data should be collected according to a protocol from a recognized international methodology, such as the WHO methodology on national or hospital surveillance of AMC. AMU data refers to estimates derived from individual patient data. Collection of use data is more resource demanding than consumption data, but the additional information provided is important for AMS programs. Point Prevalence Surveys, or PPS, refers to the collection of antibiotic treatment data from hospitalized inpatients at a point in time. Antibiotic audit data involves prospective real-time or retrospective collection of antibiotic prescription data on hospitalized patients. The data are analyzed and then fed back to the prescribers. It is an essential part of AMS programs. It is encouraged to undertake weekly or bi-monthly audits only a few patients during ward rounds, with real-time feedback to the prescribers. WHO's Global Antimicrobial Resistance and Use Surveillance System, GLASS, promotes and supports a standardized approach to the collection, analysis and sharing of AMR and AMU data. It encourages and facilitates the establishment of national surveillance systems to monitor AMR and AMU trends and produce reliable and comparable data to inform decision-making. Countries benefit from participation in GLASS through enhanced capacity building, access to training and implementation tools, and support in collecting and analysing AMR and AMU data. WHO Essential Medicine List (EML) AWARE classification has classified commonly used antibiotics into 3 groups: Access, Watch, and Reserve. AWARE is a tool to support antibiotic monitoring and AMS activities, providing recommendations on when to use the antibiotics in each category. Access antibiotics are the first choice for common infectious syndromes. Watch antibiotics are the second choice. Reserve antibiotics are the last resort options against multidrug-resistant bacteria. What is critical is that essential access, watch and reserve antibiotics need to be accessible and affordable for those who need them. These are some examples of how the AWARE classifications can be incorporated at the national level. Review or update national EMLs with AWARE. Align empirical antibiotic treatment guidelines with access antibiotics. Target, watch and reserve antibiotics for AMS. Review AMC and AMU surveillance data with AWARE. Include AWARE in health professional curricula. Microbiology laboratories play a key role in informing the appropriate use of antibiotics, ensuring first and second line antibiotics are used whenever possible. The quality of the clinical diagnosis is still essential, as the tests need to be interpreted in light of it. Microbiology supports the AMS team in interpreting and communicating results to prescribers to inform prescribing, developing and updating antibiograms and communicate their value, educating clinical staff on quality sampling for microbiology testing and AMR rates, reporting on MDR organisms and selectively reporting susceptibility data to the facility management and prescribers. On the other hand, AMS supports microbiology by ensuring they receive basic demographic and clinical data to help in analysing laboratory results. You have reached the end of Module 3. Try to answer these questions to check your understanding so far.